Today we have one special topic that is an X-ray scanogram of lower limbs, which is a very important investigation which is not widely available across the diagnostic facilities in many places. So for that we have now chief guest for this evening. We have Dr. K. Raghuveer Reddy, senior arthroscopic surgeon, expert in knee and shoulder arthroscopic surgeries, and sir has done his fellowship in arthroscopy from Manipal, and fellow in sports orthopedics from Germany, and fellow in shoulder surgery from Australia and USA, and a founder president of Telangana Arthroscopic Society, and he is the director for Sai Institute of Sports Injuries and Arthroscopy, Erramanzil and Hyderabad. With a small introduction, I invite Raghuveer Reddy sir to the this small webinar. Hello, sir.
Thanks for invitation, Krishna.
Yeah. Thank you, sir. Then today's our subject speaker is Dr. Mounika. She is a consultant radiologist at the Vijaya Diagnostic Center. She is working with us since last 5 years, and Dr. Mounika has done her MBBS from Osmania Medical College and MD from Gandhi Medical College, and worked in Vijaya Diagnostic since 2019. And she had like a lot of achievements. Like if you see, she got 7th rank in 10th class, state 7th rank, that is state 7th rank in 10th class, and got state 3rd rank in intermediate, and the state 11th rank in MSET, and got 7th rank in APPG. So all single digit ranks in the state. So Dr. Mounika has a rare achievement. So congratulations on that. And today she will be speaking on X-ray scanogram of the lower limbs. That is a very rare investigation. Like recently we got into Vijaya Diagnostic Center. We have it in 3 or 4 branches in the Film Nagar, Panjagutta, and Mayat Nagar branches especially, and a few other branches. And in outside also we have in Tirupati branch and some other branches. With this small introduction, I invite Dr. Raghuveer Reddy sir to share his thoughts on this particular study.
Scanogram we require for joint preservation surgeries, and of course normally it is done for joint replacement, but recent interest regarding the joint preservation surgery to plan high tibial osteotomy and distal femoral osteotomies, we require this scanogram.
Yeah,
We look forward for the
Dr. Mounika, you can start your presentation.
Thank you, sir. Good evening, everyone. Now I am going to start the session. X-ray scanogram of lower limb. What is scanogram? Scanogram is a special type of X-ray procedure to measure entire bone length from hip to ankle, especially for orthopedic interventions. The indications for scanogram are to determine leg length deformity and before knee replacement surgery, and to correct any valgus or varus deformities. The procedure is the patient should be in the standing position. This is a AP type of AP view of radiograph. The patella must be aligned in the AP projection with the center of femoral corners. 3 separate exposures are centered at the level of hip, knee, and ankle. Between these exposures, the patient should be motionless, and behind the patient, one indicator should be there for exact measurement. And after this, 3 images are stitched at the CR reader console using a specialized software. Like this, 3 separate exposures are taken at the level of knee, hip, and ankle. After this, these 3 images are stitched. Later, we use it to get image like this. This is the scanogram of lower limb. These are the normal physiological axis and angles. anatomic axis of femur and tibia, anatomic tibiofemoral angle, mechanical axis of femur and tibia, mechanical tibiofemoral angle, mechanical axis of lower limb, and mechanical axis of deviation. Anatomic axis, it means the mid diaphyseal line. It should dissect the diaphysis into two parts. Importance of anatomic axis is in the insertion of intramedullary nails. And mechanical axis, it means weight bearing axis. It should connect the two joints. Mechanical axis of tibia means it should be drawn between the center point of tibial plateau to the center of tibial plafond. And mechanical axis of femur means it should be drawn between the center of femoral head to the center of intercondylar notch. For tibia, both anatomical and mechanical axes are parallel, but femur both are not parallel. They use it to make an angle around 6 degrees, that is called as anatomical mechanical femoral angle. Anatomical tibiofemoral angle, it is the angle between the anatomic axis of femur and anatomical axis of tibia. Generally it is the lateral angle around 173 to 175 degrees. Mechanical tibiofemoral angle, it is also called as HKA angle, hip knee ankle angle. It is the angle between the mechanical axis of femur, that means center of femoral head to the intercondylar notch, and mechanical axis of tibia. This is the HKA angle. HKA angle is useful in quantifying the degree of valgus or varus alignment in the knee. It is also used assessing postoperative knee alignment after total knee replacement. Generally, in neutral alignment, HKA angle is approximately 1 to 1.5 degree varus, but in healthy individuals, it can vary between 1 degree valgus to 3.2 degree varus. Generally, HKA mechanical angle is more reliable than anatomical angle, but whenever femoral head is not clear in the radiograph, then we use it to consider anatomical angle. After that, mechanical angle is calculated by adding 6 degrees to the anatomical angle. Mechanical axis of the lower limb. It is also called as Mikulic's line. It is drawn by connecting the femoral head to the center of the femoral head to the center of the ankle. It means either center point of talus or center point of the lower end of tibia. Generally, this line runs just medial to the center point of the knee, around 4 plus or minus 2 millimeters. Mechanical axis deviation. It is the distance between the mechanical axis and the center point of femoral condylar notch at the level of knee. Normal value is around 4 plus or minus 2 millimeter, and more than this, medial deviation of line indicates varus deformity, and lateral deviation, this is the mechanical axis, it is deviated laterally more than 15 mm is significant, 10 mm is significant. Lateral deviation indicates valgus deformity, and medial deviation indicates varus deformity. Medial deviation should be more than 15 mm, and lateral deviation should be more than 10 mm. Two more angles. Mechanical medial proximal tibial angle. It is the angle between the mechanical tibial axis and the baseline of the knee joint. Here baseline means the line which joins the upper end of tibial condyles. This is the angle. Generally, it is 87 plus or minus 3 degrees. One more angle is mechanical lateral distal femoral angle. It is the angle between the mechanical axis of femur and the baseline of joint. Here, baseline means the line joins the inferior most part of two femoral condyles. It is also generally 87 plus or minus 3 degrees. How to determine varus and valgus deformity? First, we have to calculate the mechanical axis deviation. If it is deviated medially and more than 15 mm, it is varus deformity. Then we have to calculate two more angles: lateral distal femoral angle and medial proximal tibial angle. If it is distal femoral angle more than 90 degrees, it means femoral varus deformity. If tibial angle is less than 87 degrees, it is tibial varus deformity. If the mechanical axis is deviated laterally more than 10 millimeters, it is valgus deformity. When it is less than 87 distal femoral angle is less than 87 degrees, it is the femoral component involved. And the mechanical proximal tibial angle is more than 87 degrees, then the tibial component is involved. When both are there, it is the mixed component of valgus deformity. Next is the joint convergence angle. It is the angle between the tibial plateau and femoral condyles of tibia. This is the angle, tibial plateau and femoral condyles. Generally, they are parallel. That's why the normal angle is around 0 to 2 degrees. But in varus deformity, it opens up laterally, and in valgus deformity, it opens up medially, like this. It is this joint convergence angle also used in reading of osteoarthritis changes. General preoperative planning for orthopedic interventions. First, we have to evaluate the mechanical axis. Is it deviated to medial or lateral? Then we have to calculate the mechanical axis deviation. It will determine the varus and valgus deformity. After that, we have to calculate mechanical lateral distal femoral angle and proximal tibial angle. Is it because of femoral component or tibial component or mixed component? Then we have to calculate the joint line convergence angle. This indicates the source of any ligament or capsular laxity or cartilage loss. Next, we have to rule out any medial or lateral subluxation changes are there. Next is the intra-articular origin of the malalignment. Generally, the femoral condyles and tibial plateau should be aligned with respect to each other, but a depressed or elevated femoral condyle or plateau indicates intra-articular malorientation. This is the normal radiograph. Generally, mechanical axis should be just medial to the center of the knee, and mechanical lateral distal femoral angles should be between 85 and 90 degrees, and also tibial angle also. This is the varus deformity. In this, mechanical axis is deviated medially, and the angle tibial angle is less than 85 degrees, and femoral angle is more than 90 degrees. This is the valgus deformity. In this, mechanical axis is deviated laterally, and the tibial angle is more than 90 degrees, and femoral angle is less than 85 degrees. One more component in scannogram is to measure the length. Length of whole lower limb is measured from the topmost part of the femoral head to the superior talar trochlea. Generally, in healthy individuals, both limb lengths discrepancy should be less than 1 centimeter. If it is more than 2 centimeters, should be significant. Length of femur. Length of femur is measured from the topmost part of femoral head to the distalmost part of medial femoral condyle. Length of tibia. Length of tibia is measured from the topmost part of medial tibial plateau to the distalmost part of tibial plafon. This is the recent radiograph which I have reported. This is the old case of distal tibial fracture. So that the right limb length is decreased. Both limbs discrepancy is more than 2 centimeters. It is significant. The basic points the radiologist should report in scannogrammer: length of whole lower limb and length of femurs and length of tibia, mechanical axis deviation and HKA angle, and in special cases mechanical distal femoral and medial proximal tibial angles. This is the case of genu varum. Bilateral genu varum. In this, mechanical axis is deviated genu valgum. Mechanical axis is deviated laterally, around 19 mm in right, 26 mm in left, and HK angle is 6 degrees in right limb and around 7 degrees in left limb. This is a left lower limb genu varum case. In this, mechanical axis is deviated medially around 70 mm, which is very significant, and HK angle was 22 degrees, and mechanical medial tibia femoral angle was 76 degrees, which is less than 90 degrees and abnormal. And the lateral distal femoral angle was 97 degrees. It is more than 90 degrees. It is also abnormal. In this, both femoral and tibial components are involved. This is the case of osteoarthritis with genu varum deformity. Decreased medial joint space is seen in both knee joints, and mechanical axis is deviated medially around 21 mm in right limb, 50 mm in left limb, and HKA angle is 5 degrees in right limb and 23 degrees in left limb, 13 degrees in left limb. In this, left limb has more severity than right limb. Thank you, sir.
Yeah, thank you, Dr. Mounika, for an excellent presentation.
Thank you. Thank you so much.
This is a very new topic for all of us. Dr. Raghuveer Reddy sir has to throw some limelight on these things, like how do you use it in your day-to-day practice? When you recommend these?
Yeah, Dr. Mounika has presented in detail this about scanogram. But coming to practical point of view,
Yes.
as you know, she said it can be done in one is stitching images with 3 images or with a long cassette. One few centers they have long cassette, 1 meter length film cassette. You can take it only one shot, keeping the X-ray tube 3 meters away, and the tube should be at the level of the knee. And she already told that the patella should be in the center.
Yes.
Because the value changes, so we keep the limb slightly internally rotated.
Yes.
It has to be done by the technician properly, because if scanogram is taken in proper way, the whole surgery planning goes away.
Okay, sir.
So if you take a scanogram in neutral, external rotation and internal rotation, whole planning changes. So it has to be done in internal rotation, patella facing in center, already she told. And pelvis should be squared. If they have any limb discrepancy, keep the height, see that pelvis is straight. Then you shoot the images. Yeah. And normally, suppose we plan either by pencil or pen method or use a software. If you use a pencil and pen method, we don't require any marker.
Okay.
Suppose if I use a software, so what I take a JPEG image, I click from the camera, then I calculate my planning. Suppose if I want to do high tibial osteotomy or distal femoral osteotomy, then I have to see the marker size. So whenever I send my patient, I give the patient a marker, whichever size, 2.5 centimeter, 5 centimeter. So in all the films, you keep a marker. So when I plan in software, I take the consideration how much is magnified. So this is a point is important for us for technical, for radiological technician point of view. So sometimes if I am not happy, I repeat the scanogram twice or thrice.
Yes.
So whole surgery depends on the scanogram.
Okay.
So we train the technician properly. So I send the scanogram only to the particular 1 or 2 places. So the technician knows what I want.
Yes.
This is about scanogram AP. In some cases, we take a lateral view scanogram also. Suppose tibial slope correction, all that. Standing lateral view, hip, knee, ankle. So that is slightly difficult, but we have to be there at time of this thing. This is thing what I want to tell, that's all.
Indications, what you mentioned, sir. Indications regularly. What indications you use?
Dr. Mounika has already covered. This is for coronal malalignment. for varus and valgus deformity. They has told that that's why for us we require only 3 values commonly we use: MPTA, MLDFA, and JLCA. Depending on that, we plan the surgeries, especially commonly medial open wedge high tibial osteotomy. We plan.
Okay.
There are different ways to plan the surgery. That's why we do. That's why scanogram is very important.
Yeah.
Okay.
Then only we draw the lines. We taking the proper wedge. How much to take? If you are planning a high tibial osteotomy, it can be a medial opening wedge or lateral close wedge or high tibial osteotomy. For the calculation of the wedge, we do all these values.
Okay.
How much varus correction? If you have varus knee, we do medial open wedge high tibial osteotomy. Suppose
Sir,
the
I
patient
have one doubt. Sir, if
Suppose
both tibial and femoral components are abnormal, then
yeah, that's
also
why
we use it to do
we do
osteopathy.
at 2 levels. Suppose the varus is low, more is there, both at femur and tibia, then we correct at 2 levels. So commonly what we use a lateral close wedge distal femoral osteotomy.
Okay, sir.
Lateral close distal femoral osteotomy and medial open wedge high tibial osteotomy.
Okay, sir.
So we do a 2 levels correction and we get the Miculus line in the center, mechanical axis, which is shifted medially. We try to bring it to the
Just
center.
okay.
So if you try to, if this a patient is having gross varus, you showed that one case around 13 or 14 degrees of varus is there. If you try to correct everything in the tibia, then JLCA becomes reversed. You said JLCA normally opens medially, means it is directed medially.
Yes, sir.
Yeah, if you correct everything in one level, there will be a reverse obliquity.
Oh.
JLCA, which has to be apex medially, apex
Yes,
becomes
sir.
lateral. So there will
Yes,
be
sir.
reverse obliquity. That's why
Okay.
we do more corrections. We distribute the correction in femur and tibia
Yes,
to
sir.
keep the JLCA parallel near about.
Yes, sir.
That's why this is for, we take the scanogram, which I've been doing past 10, almost 15 years. But initially, 20 years back, we didn't have the stitched images.
Yes.
So what I used to do is we take a large cassette and put a K-wire attached with just sticking elastoplast. Do same thing, 3 films.
Yes.
And then we overlap all 3 films with the K-wire.
Okay, sir.
So now we are stitching it digitally.
Digitally,
Earlier we used to do manually.
Manual stitching, correct.
So we used to put K-wires on the X-ray cassette and take at three pictures.
Oh.
One K-wire knee, one K-wire thigh, one over the tibia. This we have done almost 25 years back.
Okay.
So now we are doing it. What you are doing manually, you are doing it digitally, stitching.
How you find it different from CT scanogram, sir? CT scanogram of the lower limb. Do you find it the same as?
No, CT scan is not standing. That's why for me, X-ray standing is important because the weight bearing. CT, if you do, it will be in supine and non-weight bearing. So for us, standing scanogram X-ray is more important.
Yes.
So any lateral ligament, Dr. Mounika was talking about lateral ligament laxity and all that. So
Yes.
it helps us. We know the real Miculus line where it goes. So standing X-ray scanogram is more gives more information than CT scanogram.
Okay.
Maybe CT scanogram, maybe for the limb length, you can, that is fine.
Only for
Yeah, limb length, bone defect, that may be
Sufficient.
But when you're planning for the bony correction, HTO and realignment surgeries, standing is better.
Sir, I have one doubt, sir. For Ilgerow's method, how much should be the limb length discrepancy, sir?
No, I'm not a laser or reconstruction surgeon, but
Okay,
I
sorry,
think
sir.
well, it's fine. So one of the main indication of scanogram is one is shared replacement.
Yes, sir.
One is joint preservation surgery, and regarding the limb length, what you're talking is for people
Yes.
who are doing the laser. So up to 2 centimeter body can adjust the discrepancy.
Yes.
You can without doing anything also, or just only shoe rise, we can adapt. Anything more than 1 inch, you require limb lengthening,
Yes.
it's bony correction. Up to 2.5 centimeter, what you said, body can adapt.
Yes, sir. Okay.
Later we can give beyond 2.5 centimeter, we have to give the shoe rise.
Okay.
So, one last question, sir. How do you find the radiographs? Like most of the times, you accept these X-rays, or you want them to be repeated sometimes? Like
Yeah, that's why initially, that's why we will come to know whether he has taken in the limb in neutral or external rotation. So we have to see that it is taken properly. See the pelvis is squared, center of the patella, and see the slightly limbs are internally rotated. And then the scanogram is correct.
Because everything depends on how much you have to take that wedge and all that. So I
Yes,
think it's
everything, whole planning surgery depends on scanogram.
Yes, so much importance.
Yes. So that's why I made it see that it is done in my wherever sent in your centers.
Correct, exactly. Yeah. Now that Dr. Monica is expert in that, so she will give you her things.
Thank you. Thank you so much.
Thank you, sir. Thank you for sparing your valuable time. And this is very much helpful for the people who will be doing the X-ray or will be want to learn about these things, because this goes to online and it will be available in Facebook, YouTube, and other mediums also. Thank you so much. Thank you, Dr. Monica. Thank you, Raghuveer, sir.
Thank you. Thank you.